A very good morning to all my dear students. Today, we are going to deal with the topic Endo, Perio, Lesions. I hope you all must be familiar with this Endo, Perio, Lesions during your discussions and previous theory classes. So, today's class, I'll be dealing, or I have divided the topic into 3 different sessions. The first session being the etiopathogenesis of endoperio lesions, classification, which covers the classifications too. The next session, I'll deal with the diagnosis, treatment plan. And the third session, I will discuss about few cases as well as the multidisciplinary approach to manage those cases. So, what are the objectives of today's class? To understand the etiopathogenesis of endoperio lesions, provide a clear guidelines to diagnose endoperio lesions, formulate prioritized treatment plans utilizing endodontic, periodontal, and combined approaches. And the fourth objective being to evaluate the prognosis and establish long-term management for treated endoperio lesions. So from this topic, the university questions, most commonly they ask essay topics, like essay questions such as define and classify endoperio lesions and diagnose and management, and short notes being the classification of endoperio lesions, pathways of communication for endoperio lesions, and the similar question like diagnosis, specifically the diagnosis of endoperio lesions. So kindly make a note of this important university questions. So coming to the topics, this endoperio lesion is a common clinical scenario which you encounter in your clinical practice. As well as you all are very familiar, both dental pulp and periodontium, though they are biologically different tissues, but they share common factors or risk factors when there is a disease process occur in both of these tissues. So what are those shared risk factors? As you all know, the microbes being, they have a common microbial etiology, as well age, to an extent, the diet factor, the risk factors like smoking, and to an extent, the genetics, stress, and other systemic connections, and the lower socio-demographic factor like the lower socioeconomic status. So what are the pathways connecting endodontic and periodontal tissues or lesions? Like, it can generalize we can generalize the pathways into or categorize the pathways into anatomic, pathological, and iatrogenic. So predominantly the anatomic considerations, the etiological factors and contributing factors. And yet another way you can put up the etiology. As mentioned in the slides, you can clearly make out of the live pathogens, which can be a sole cause for initiating and and responsible for progressing the lesions, like the bacteria, fungi, and viruses. Non-living etiological factors such as extrinsic agents, intrinsic agents, and the base causes, other causes like the poor endodontic treatment, poor restorations, trauma, resorption, perforations, and developmental malformations. So when you look into the anatomical considerations, you can see that the apical foramen, the dentinal tubules, and the accessory lateral canals, these are all like the anatomical factors which are responsible for the initiation and progression of these two lesions. Next comes the pathological factors like the root fracture, the crown fractures, the external resorption as mentioned in this radiograph, the vertical fractures, the internal resorption. These are all the pathological reason. And the iatrogenic factors, example, for example, the excess heat during cavity preparations or even during any dental procedures, the perforations, overfilling, over instrumentation, these can be put under iatrogenic factors. And let's recap what we have covered so far. So we have discussed about the, mainly we have discussed about the what is endoperio lesions and what are the important risk factors, shared risk factors between these two biological tissues, and what are the factors responsible, like anatomical, pathological, and iatrogenic factors which are responsible for endoperio lesions. So I need to highlight one thing here, that is exposed dentinal tubules will always create a communication between pulp and periodontium. Everybody knows this. I think you can see the right-hand picture and how well it is connected to the external tissues. Like that means of an aggressive scaling technique or a faulty scaling technique, or following a root planing procedures where you instrument more, or you can damage the tissues, the hard tissues, the gap joint between enamel and cement, and that is at another, like potential area, and even gingival recession and during root caries formation and cervical abrasion. These are all the potential communication between pulp and the periodontium, and there arises the lesion you call it as endo-perio lesion. So this is a very important picture you need to remember, like, that whenever you do any procedures, you need to be very careful. Never do over instrumentation. You have to respect the hard and the soft tissue when you do a procedure. Maybe, like that means the iatrogenic factors that you can control within your limits. And when you look into the pathogenesis of endoperio lesions, not much is given in the literature, but it is very clear that, it can cause retrograde periodontitis or retrograde pulpitis. The, like the root causes being, as I mentioned before, the all those factors, the or like the microbial etiology, or a fracture, or a, like a excess heat, or like any causes that can stimulate the or can damage the pulp, that will cause an intrapulpal increase in the intrapulpal pressure, that in turn can force the etiological agents or the microbes in towards the apical foramen and push towards the alveolar bone area, where it can initiate, or it can activates the osteoclastogenesis process and cause either the root resorption or the alveolar bone resorption, and causes what, it leads to retrograde periodontitis. That's how it is linked from endoperio lesion. In other ways around, even the primary etiological factors, like for initiating periodontal disease, includes the gram-negative Aerops can breach through the gingival epithelium, and if it is not rectified, or it is not managed at the initial stage, it can progress to periodontitis, and it can reach it up to the root apex, and in turn can, through the apical foramen, it can cause retrograde pulpitis too. So both way it can be connected. So up comes the very important short note, or you may all have to remember this slide, like it is not just, from the basic text, what you follow. Which one? Yes, you follow Carranza's textbook, no? Like in that textbook, it is, they have described, or they have followed only one classification to describe the whole lesion. But in actually may have to remember all other classification. There are numerous classification from this topic, but at least you mention 5 or 6 classifications for your question to answer those questions. So those classification, the old one, this Simon's classification 1972, Dietrich in 2002 classification, and Kim and Kretschmann's classification in 2006. Those are all the classic classification. The latest being Herrera's classification under 2018 or 2017 put forward at the revised classification for periodontal disease, which we follow for postgraduates now. As of now, for undergraduates, basically we follow the classifications put forward by Simon Glick and Frank in 1972, which is very simple for everybody to remember. Or I think from the picture itself, it is very clear. So it is very important. You all have to draw this diagram as well when you put up the classification for endo-perio lesion. That is primary endo, and secondary perio, primary perio, secondary endo, and true combined or combined endo-perio lesion. So this is a very beautiful classification, and everybody can easily follow this classification, and don't ever forget to draw the diagram as well. So coming to the diagnosis of endo-perio lesions. So always this diagnosis is always a dilemma for both endodontist and periodontist. Make sure that before you diagnose, you have to have a checklist, and that the data should be collected well, and should have a thorough medical history and a oral clinical examinations. And when it comes to periodontal examination, make sure that you are checking. You have to examine the gingival the color, consistency, the contour, the stippling, the bleeding status, and the pus expression or the exudate, and periodontal pocket, mobility, furcation involvement, etc. And you have to evaluate what the test which is done by the endo part, like the pulp vitality test, or you can as well refer. If the case is first coming to a periodontist, you may have to refer the case. You can advise for those investigations like the pulp vitality test. You have to do a percussion test, palpate, and very importantly, sinus tracking. And as well as you have to check whether it is a cracked tooth. And it is a rule that you have to correlate your clinical examination with the radiographic examination. So coming to the periodontal examination, from the slide itself is very clear the areas you have to focus on. The gingival examination, as I mentioned before, you have to check the periodontal phenotype. Though the term is little new for the undergraduates, it's nothing but the gingival thickness, whether it is thin or thick, which is very important when it comes to the treatment aspect, especially the surgical aspect. And it is very important to check the width of attached gingiva. And I think as undergraduate level, you are all very well, superb in checking the periodontal pockets, I believe. The periodontal probing and the furcation probing, you have to use the neighbors probing to check the correct furcation or detect the correct furcation involvement areas. And the tooth mobility, as the picture clearly shows, how you have to hold the instrument and assess the tooth mobility. And it is mandatory that you have to check the occlusal status or trauma from occlusion, the latest term being excessive occlusal force. And you have to make sure that the tooth which is having a endo-perio lesion or a combined endo-perio lesion, make sure that the tooth is relieved from occlusal force. And always, it is very important to check whether there is any abscesses. The abscess can be commonly associated with endo-perio lesions, can be of periodontal or a periapical. And from the location itself, you can make out if it is periodontal, means the involved area should be like attached to gingiva, or you will see it on the lateral aspect of the root. Whereas as periapical means the swelling will be seen like above or below the mucogingival junction. So the location of the abscess onto the anatomical area is very important to make a proper judgment. Another area along with swelling, if it is a chronic lesion, you can see that pus is draining from the sinus tract. If not, the sinus tract is is commonly seen on the chronic lesions. whereas there will not be any sinus tract in acute conditions. So it is very important, you have to correlate with other acute condition, findings as well, but make sure that if there is a sinus tract, it is easy for you to do a sinus tract tracking using Gata-Pacha cones and take a radiograph and confirm from where the origin of the lesion is. So this is a picture which depicts how to do a sinus tract. You can see a small Gata-Pacha cone is inserted through the sinus tract opening, and then you will take a radiograph, and you can clearly make out from where the lesion is originated from. So this is very important, as I mentioned. Always radiographs are a diagnostic tool, as you can put it as the adjunct diagnostic tool. You cannot come to a final diagnosis without the help of a radiograph. You can either use a IOPR or a bite-wing, or you can at times the suspected case where you find it if there is any fracture, better I advise to go for CBCT. This is the CBCT image, and you can make out very clearly how the clarity of the presentation of the lesion, and you will give you a 3D image, and this is the best tool to have to make when there is endoperio lesions associated with the fracture or a cracked lens. So coming to the examination, for for every student, the time management to write the entire topic is always challenging for any student. So for this topic, I suggest you can all use a table to make a differentiation between the lesions as well, so that you will cover the topic. You will present the complete theory topic as well. So, you can put up the headings like the examinations, the primary patient symptoms, the coronal integrity, radiographic lesions, vitality, periodontal probing onto the other end, onto the side, and you can differentiate between the lesions as well. If it is primary, pulpal, or endo, what are the patient symptoms? It varies. There will be mild discomfort in independent perio endo lesions. It will varies. Again, combined, it will vary. Coronal integrity, which is a very important thing you have to make out. It is compromised. In primary perio, it will be intact, and the compromised in the case of independent endoperio, again combined, it will also be compromised. And when you see the radiograph, you can very well appreciate the periapical radiolucency in the radiograph. In the case of a primary endodontic lesions, crestal bone loss is very well appreciated in primary perio. And if it is a independent lesion, you can see both periapical and crestal lesion, but it will not be connected. Or when you look out the combined endoperio lesions, you can see a continuous bony lesion from alveolar crest to apex. And vitality, as everybody knows, that the primary periodontal lesion will be always vital, where when there is an endodontic component added to it, the tooth vitality will get compromised. Okay. And periodontal probing, in primary pulpal, it will be narrow probing to apex, but even whereas primary periodontal, you can see the probing will be deeper, and endodontic also there will be deep periodontal pockets as well as combined. It is very clear that it will be the pockets as well as radiographic bone loss will be there. So coming to the prognosis and the treatment plan. The prognosis and treatment of each endoperio disease type varies. Primary endo should all be treated by endodontic therapy and has a good prognosis. And primary perio should only be treated by periodontal treatment. The prognosis depends on severity of the periodontal disease and patient response to treatment. The combined lesion should be treated with endodontic therapy first. That should be a golden rule. And treatment should be evaluated in 2 to 3 months. That means once the endo treatment is completed, you can give a break period of 2 to 3 months to evaluate the condition. And this sequence allows for sufficient time for initial tissue healing and better assessment of the periodontal condition to determine if the tooth needs a scaling, root planing, or a surgical treatment. Most of the cases, if it is a primary endo, the lesion will subside completely after primary endodontic treatment. And the prognosis depends on the periodontal involvement and its treatment course. And the cases of true combined disease usually have a more guarded prognosis. So this is yet another beautiful slide. Everybody can have a quick review. That is, decision making tree for perio-endo lesions. So what is it? It is a primary endo, as I mentioned before. Do endodontic therapy and go for revaluation. If it is a primary perio, give periodontal therapy and then give for periodontal. Then you go for a revaluation. If it is a primary endo and secondary perio, again start endo, then perio, and then reevaluate after 3 months. And if there is a primary endo lesion with iatrogenic or a root fracture, seal the exposure and root fracture management. And primary perio and secondary endo starts with endo, then perio, and then again true combined starts with endo and then perio, and completion of endo with perio. That means these conditions you have to wait for a time frame of a 2 to 3 months period and then initiate your the perio treatment. And during the evaluation, which is very, very important, during evaluation, no resolution, go ahead with the decision. If it is a hopeless prognosis, go for extraction. And if there is a resolution, no resolution, again, you have choice for hemisection, root resection, bicuspidization. And then again, those conditions, if you're choosing resective surgical treatment, root resective surgical options, again, you have to go for a reevaluation after 1, 3, 6, 12 months. And then at some conditions, you can even think about going for an apexectomy. Again, you have to reevaluate. And if there is a periapical resolution, and again periapical lesion, so you have to go for a periapical surgery. And even periapical surgery, doing when you do a periapical surgery, also if the teeth is exhibiting mobility, go for splinting, and then you do the procedure and then you evaluate. And after 2 to 3 months, you can go for the final restorative options. So let's see a case where endoperio lesion. There is a case from the radiograph. You can clearly make out there is a periapical lesion, and it's an RCT treated tooth, but still there is a lesion. These conditions, you have to think about going for a surgical option. Have to go for a surgery, periodontal flap surgery, reflect the flap and assess the area, do a thorough debridement, and minimize the bone exposure, as well as you have to, you can see the lesion is so extensive. There is a perforated cortical plate too. But still, if there is no tooth mobility and the prognosis is fine, means you can think about going for a graft procedure along with GTR membrane. And you can see it is open and it is sealed well with the bone graft and the GTR membrane, and the lesion is well sutured, and this is the post-op review. Understand? So you can very well appreciate in the radiograph how well the periapical healing has happened. Clear? Now let's see few clinical cases. Case discussion. This is a case discussion which is meant for root resection. Okay, so you can see the patient has complained about swelling and pus discharge from lower mandibular tooth. And on radiographic examination, clinical examination, we have found out that deep periodontal pockets, tooth is exhibiting mobility. And but one thing good about this case is that only one root is deeply involved. So we thought of going ahead with the hemisection procedure. So we have done a hemisection procedure, and then that means you put, like you will put as under bicuspidization, in fact, and then we have gone for an FPD placement for this case. This is an activity for you. Just check it. So this is an endoperio lesion affecting the tooth 4-3. The initial presentation of 4-3 with deep periodontal pockets greater than 6 mm, affecting the buccal, lingual, and distal aspect of the teeth. So, my dear students, just do a homework, discuss about the prognosis, diagnosis, prognosis, and management. It's just an activity for you. I hope the picture is very clear. You can click a picture on the slide and just work out. From the theory portion which I have discussed so far, you can apply the theory aspects to this clinical case and just come to a diagnosis. This is very clear. It is an endoperio lesion, no doubt. So the prognosis is still questionable or hopeless. Still, it is a questionable, or you put it as an fair prognosis where it is treated well. Again, flap surgery needs to be done. Endodontic management, you can see that after endodontic management itself, the healing has not completely, incomplete, or I should say, the periapical lucency still persist. Have gone ahead with the periodontal management because the periodontal probing depth is also like more. And then with the bone grafting and GTR membrane, we could able to achieve or get back the health of the tooth. Yet another case, I think you all can do this activity, discuss about the diagnosis, prognosis, and management. Yet another case, and this case itself very clear. The probing has gone to or shown only for one mesial line ankle, but still from the radiograph, it is very clearly seen that the furcation radiolucency is very clearly evident. I hope it is should be a through and through lesion, or it could be like could have been felt to be grade 2 thing, because the case itself we managed it with the like to perform regenerative procedures, it should be a grade 2 furcation lesion, because that grade 2 has a better prognosis as compared to the grade 3. We've used bone graft and membrane, and then we have sutured back the flap in position. And this is a radiograph which is taken after 6 months. You can see that 3 months, sorry, and you can very well appreciate the bony changes in the radiographs, the bone fill. So at the case where there was a persistent endoperio lesion, this is activity number 3. So you can see the recurrent abscess formation onto the tooth number 21, where RCT was initiated, but there was a persistent endoperio lesion, means there should be a perforation, or it has gone to the lesion is gone or focused more on to the periapical region as well. And again, the flap is raised, and it is a circumferential defect. Placed the bone graft and GTR membrane, and the flap is positioned well with the sutures. You can see the post-op picture as well. So again, whenever you manage a tooth with endoperio, if it is in a manageable state, if it is a grade 2 mobility, and make sure that if you're planning for a regenerative procedure, you have to splint the tooth, and the tooth should be relieved from occlusal trauma before you initiate a regenerative procedures. So to conclude, the diagnosis and management of endoperio lesion is a clinical challenge. The prognosis of combined diseases rests with the severity and the extent of periodontal lesion and the efficacy of periodontal therapy. So the multidisciplinary management is essential for favorable outcomes, and following a staged approach seems sensible. So to summarize, so as I mentioned before, Today's class topic was on Endo-Perio lesions. The initial session, we have discussed about the etiopathogenesis, then the classification, diagnosis, prognosis, diagnosis, and the treatment aspects. And then we have seen few clinical case or clinical case discussions, and I've given you 3 activities to work on. Understand? So this topic is very, very important for university exam. And, the whole topic can come as an essay, or, the classifications or the etiopathogenesis of endoperiolesion can be asked as a short note. So what are the take-home messages from today's class? Establish a correct diagnosis, correlate the clinical and radiographic findings. Arrest the disease progression by providing appropriate treatment strategies. And always, or you choose multidisciplinary approach as when required. It is very important that, for the cases like true combined lesions, it is always, or, primary like perio and secondary endo, those situations you have to depend on endodontist for their support in managing the case with root canal treatment. So I need your feedback. It is very important. And if there is any doubt clarification, you can come and meet me in person, and I'll explain to you in detail, and come with clinical scenarios too, so that you will understand this topic better. So thank you all. Thank you all for your patient listening.